Good afternoon, everyone. Thanks for staying here right to the very end. I'm glad to see that many of you are still fresh and awake, although I suspect after I'm done that may not be the case. I've actually learned something very important during this meeting, actually. Never speak after Dr. Sada. I'm not sure what I have to show after this will be half as interesting, but let's give it a try. So I'm going to talk about the interpretation of OCT in both diabetic macular edema and retinal vein occlusions. And I'd just like to acknowledge my co-investigators and my disclosures. So as we know, diabetic macular edema is a leading cause of visual loss in diabetics, and prevalence in diabetes is high and is increasing in some populations as well. And of course, DME can cause quite a significant amount of visual loss, which can result in treatment. Retinal vein occlusion is also a very important cause of visual loss amongst the retinal vascular diseases, and macular edema can occur both secondary to branch and central vein occlusion. So what are the factors that can affect visual acuity? These some of the factors that we would want to look at: the amount of retinal thickening, whether there's macular ischemia. We can't really see that very well on OCT, but we'll need a fluorescein angiogram. And also we'll go into greater detail. We want to look at the photoreceptor status, as well as whether specifically the ISOS, or now the ellipsoid zone, is disrupted. So when we assess macular edema, traditionally how do we do it? Obviously we've used clinical examination, we've used stereophotography, but these, whilst they serve its purpose and it's obviously an important skill to have, are not ideal because they can be subjective. When what one person sees, another may not, and it's also insensitive to small changes in retinal thickening. Right? Frankly, I try to test myself in clinics. Actually, I'll actually examine the patient before I look at the OCT and not be influenced by this. And sometimes I'm happy in the sense that I pick up the areas of thickening and edema, but at other times I realize, just completely wrong. I think it's edematous and it's not, or vice versa. Maybe I shouldn't have said that since my boss is in the audience, but never mind. Anyway, let's talk about, so OCT is obviously an important tool that we use to help us screen and make management decisions. So we can look at the quantitative factors. First of all, some have suggested that you can use the central subfield thickness, that's the mean retinal thickness within the central 1 millimeter of the ETDRS grid, and correlate this with visual acuity. So, and you can see here a list of some studies that have actually tried to examine this, and the R square, which is the amount of change that's explained by that, varies from all the way of 0.13 to perhaps as high as 0.54. That's not very ideal. So the correlations have been found to be at best modest, and I think this is something that we need to think about, that basically just the amount of thickness does not always predict the level of visual acuity. So another way of using quantitative OCT thickness is one paper that used participants from the Cruz and Browder studies, where they divided the patients into early and late responders. This was based on the central foveal thickness or central subfield thickness at 3 months. And they found that those who had less than 250 micron thickness at 3 months had a better visual outcomes compared to those with more than 250. So if they responded early, they tended to have a better outcome, right? But this is something that's not always very easy to apply. And also, before I forget, as Dr. Sada mentioned, when we talk about the central subfield thickness, remember, I think it's important to remember which OCT device you're using. You can't compare between, say, a time domain OCT used previously and a spectral domain OCT that you just brought into your clinic, because even if we measure the same patient, same day, same time, using different machines, inherently you're going to find a difference because of the segmentation algorithms. And of course, there's the issue of segmentation errors, as well as the plain measurement differences. So let's also look at some of the qualitative features on OCT. So these are some examples. In diabetic macular edema, Otani and Kang have described some similar classifications. This was based on time domain OCT, and basically they have 3 types of patterns, where type 1 is described as a diffuse sponge-like retinal thickening, whereas type 2 is more cystoid in appearance, and type 3 has actually subretinal fluid and perhaps vitreomacular traction as well. That's 3A and 3B under the paper by Kang, which was actually modified from the Otani classification. And they have suggested that there are differences in visual outcomes between these groups of patients. Now, is that true? Well, we looked at some of our own cases, and we found that essentially the most common was type 1, and the second most common was type 2. There was very few type 3 cases, so we left those out of the analysis. We found that the type 1s had a better, high rate of resolution of CSME, as well as a lower rate of worsening visual acuity compared to type 2, and that's especially dramatic if you look at this, 12% versus 82%. Some other factors that have been suggested as qualitative features for DME include the amount of whether it's diffuse parafoveal macular edema. But of course, one issue about qualitative assessment is it is a bit more subjective and can vary from one person to another. Another thing they've looked at is the integrity of the IS-OS junction, and basically you can either look at it as whether it's present or absent, or you can actually, some have even broken it into estimating the amount of disruption. So when you look at grading like so, you can look at whether it's intact or whether there's a disruption. And of course, different papers have used different amounts of disruption. In this case, 200 microns. You see another one later that used 500 microns. So what's the correct answer? Right? They've also looked at the percentage of disruption, so from 0 to 100, and these are just examples of the different grades. So as you can see from this, the grade 1 has a fairly intact IS-OS line here, whereas grade 2 there's a disruption, and in grade 3 there's an even larger break in the line. Obviously, I think Dr. Sada mentioned, he gave very good examples of artifacts earlier, which you need to consider before you can actually make that diagnosis. If there's a very dense opacity, causing shadowing, then you can't really tell whether there's a loss of the IS-OS or whether it's just not visible. And in one of the papers has actually shown that the percentage of disruption of the IS-OS actually correlates with the number of ETDRS letters lost, but I think you'll probably agree from this scatter plot that the dots are all pretty widespread and may not be, and as always, it may not be very indicative. So this has been looked at in retinal vein occlusion, whether it's just normal, abnormal, that means there's still some signal, but it's speckled or irregular, and another one where it's not visualized. And in this particular study, they actually found that both the VA score as well as the central point thickness tended to vary. It was worse for those where it was absent. It was intermediate kind of VA as well as point thickness for those with abnormal IS-OS, and for those who had normal IS-OS at 112, the vision was the best, and of course the central point thickness was within the normal range. So other factors that are important to look at qualitatively would be the presence of intraretinal cysts and subretinal fluid. This will thus give an indication of disease activity, and of course, I think we've seen many examples during the course of this meeting of how we use serial OCTs to assess the changes in these various features over time and with treatment. And also those, again, studies have shown that those with persistent cystoid macular edema tend to do worse, which is kind of expected, but it's nice to actually have the data to prove this. So to summarize the OCT features for retinal vascular diseases, I think the quantitative changes do play a role, but you must take that and with a pinch of salt and know what you're looking at. And for qualitative features, you would want to look at the patterns of edema, the presence or absence of cysts, or diffuse thickening, whether the subretinal fluid, and the IS-OS has also been shown to be of importance in evaluating outcomes for these patients. Thank you.
Maybe a quick question, otherwise we'll move on. We'll have questions at the end too. So next I'd like to introduce once again our good friend, Professor Giovanni Stalenghi. He's going to start the AMD section of our course. and giving us an introduction to the use of OCT in the management of AMD.
Thank you. Okay, so as we heard since yesterday, and probably everybody knows about the treatment regimens. We have a monthly injection of the anti-VEGF, the loading phase, and then PRN, like the old European label. Then the new European label, it's one injection every month until the maximum vision is achieved. It is stable for 3 months, or monthly when is needed, by like the CAT study, or treat and extend. So you have many possibilities, but of course, except the first one, all the others needs to be, the activity of the lesion be recognized. So these are the criteria for retreatment. We start with the Pronto for the first year, and you see that there is an increase in OCT central retinal thickness, at least of 100 microns, visual acuity loss at least 5 letters, new macular hemorrhage, new area of classic CMV, and evidence of persistent fluids on OCT after the previous injection. Now, there are other studies that use a PRN. The SUSTAIN was a sponsored trial by Novartis, and actually used such a criteria. The difference, as Phil told me today, was that SUSTAIN was based on the idea of the principal investigator. So the principal investigator can decide to treat or not to treat depending on the activity. But then every time, every month, he has to decide. Phil, actually in the Pronto study, once it was recognized a reactivation of the lesion, was treating until there were no fluid anymore. So that is a little bit different, but can create a difference in the results. You know that Pronto has better results, similar to monthly injection, but not the SUSTAIN, that actually have a little bit of decrease. Phil, correct me if I'm wrong. Okay, perfect. Then, in the second year, the Pronto actually changed a little bit and was more aggressive. So it means that we were not waiting up to 100 microns, but any kind of fluid was treated. And I think also in the second year, you still using the time domain OCTs, and not just the spectral domain. The CAT actually use exactly the same. Yes, all the time domain, exactly. Except for CAT, for the second year, that accept the spectral domain, but we have just few centers. Why I'm saying time domain and spectral domain? Because here is the same case, and you see with the time domain, probably you will not recognize easily that there is some fluid, but you actually see over here. Of course, I'm not completely sure that the two scans are taking the same position, but in any case, that could happen. A spectral domain is much better to recognize because of what you heard from Professor Sada, and here you actually see an example of what you can miss. So probably here you would not retreat. Of course, based on Pronto second year and the CAT study, you would retreat. But there are other signs, as we said yesterday, for recognizing the activity of a lesion or the not activity of the lesion. For example, here it's outer nuclear tubulation, and that you will not consider. Probably here it's probably should be considered like a fluid, but if you look carefully here, it seems that an outer nuclear tubulation is forming in that way. Then you have fluid over here, cyst over here, and these are considered signs of activity. And moving up, probably you will not see, even if we actually saw yesterday, and this is why I'm forcing the idea of multi-modality, you probably cannot get an idea. But here it's, even if probably here, if you don't look at the fluid, but if you look at other signs, like for example, this one is clear here, where you have such a changes in reflectivity that could be a sign of activity. And also the hard exudates and the cysts that we said before. Now, since it's late, it's the last day, we will go through some cases, and I hope you will enjoy. It's a quite strange case. So a male, 68 years old, 2020-2032, progressive disease, decreasing vision in left eye in the last 2 months. And here is the case. Infrared, some motor pigment here, retinal pigment epithelium detachment, autofluorescent, no big changes, fluorescein, quite normal. ICG, okay, you see a kind of masking effect of the retinal pigment epithelium detachment if you do an ICG with a scanning laser. And here the OCT. There is some small detachment. What do you think? It's an active CMV, or it's just a serous retinal pigment epithelium detachment with a small serous detachment, as most of the time you can actually get. So we actually look at him, and he came back 2 months later with a decreasing vision and such a things in infrared. So what is left? I can show you the blue light, nothing. The autofluorescent, I'm sorry because the quality here, but here it's black. I can tell you from the screen. And the fluorescein, it's like that. Now it's a choroidal neovascularization. What do you think? I think I have the ICG. And you see that, just to give some tricks to recognize when I'm reading the ICG, you see that this is a choroidal vessel that continues over here. You see? So this is not actually a choroidal neovascularization, it's just lack of masking effect. So knowing that, knowing the autofluorescence became black, what you can actually see in the OCTs, in that point, it's a rip of a retinal pigment epithelium. So it's unusual to see a rip in the retinal pigment epithelium in a serous detachment. So we didn't do anything, as you can imagine. So some months later, so that it was before, some months later he came back with another decrease in vision. And you see here it's completely changed. There is some fluid over here, something strange over there. And just to give you some images and fluorescein. And the ICG. So you see a polypoidal lesion over there with a strain, with blood, fluid. I could say it was unexpected looking at the retinal pigment epithelium detachment in the center of the forehead. I actually went back and see if there were some, lesion over there at the beginning, creating that detachment, but I was not be able to get. So here it's the situation with the OCTs, and this is the, sorry for the quality of the images, but you see it was quite a disaster. So, sorry, second case, 78-year-old man, 2200 in the right eye due to a RAP lesion that he discovered 1 year ago, and he came for a routine visit, sorry, misspelling, for the retina for left eye. Yeah, actually for the right eye, but we were actually looking at the right eye and we saw such little things over here that correspond to this part. And 15 days after he came, because he started to complain of visual acuity, and you see here the hemorrhage, and probably we were, and you see after that, a RAP lesion, a clear RAP lesion, and as Vas was underlined, a cystoid macular edema in a choroidal vascularization, you always have to think about the RAP, reticular pseudodrusen, you know, a peri-foveal hemorrhage, all sign of a RAP lesion. So we treated successfully, everything was almost perfect, still back on that little things, but it comes back, and as you can imagine, every time we see fluid, we retreat it. The only problem is that should we treat it, in this case is treat and extend, and I would ask to all of you guys what you are doing. You actually, since we know that the RAP lesion is very aggressive, both eyes in less than 1 year involved. We know that you need, and the Pronto study, by the way, underlined the fact that the lesion that needs more injection was a RAP lesion. We should continue treat or just treating when the fluid is coming back and the reactivation of the lesion. Probably don't know. So just going back to the case and seeing that there was many times of reactivation and closure of this vessel. Last case, female, no, I'm sorry. It's full of this. Visual acuity, 2060. Also, I was tired. Hey, exactly. And yes, Ms. Blind. Thank you. Seriously, this needs spelling also that because it should be I. It's a mixture. Okay. So it's progressive decreasing vision in right eye in the last year. This infrared image, the autofluorescence, nothing in particular. The blue reflectance, fluorescing, but the ICG is clearly shown a very nice occult CMV. Another trick for detecting the ICG, the image, the lesion, is that you see this huge choroidal vessel, vein vessels, and you actually see that it's masking, so that it's actually the lesion. All the masking tissue, because actually it's closer to you, and if you take a stereo, you will see very well that it's covering all the choroidal vascular, normal choroidal vessels. So, occult lesion, of course, if you look at the OCTs, and you can actually see a very nice lesion. So, we didn't do anything. We decided that the fluid was not enough to be treated. Visual acuity was still good. So we had a close control, and here is the situation. What's happened is actually, you see a denudated RP, so it's actually a choroid, so it's a rib, not visible here, not clearly visible in fluorescein, but clearly visible in ICG, and of course, if you look at the OCT showing exactly the same. One thing that you have to consider is that sometimes, not all the time, but sometimes the RPD regrow. So you can actually have, and this is why, you remember the first rib, the fluorescent was very, very, more than the size, because it was leaking the choriocapillary. You were actually directly a choriocapillary effect. Here you have masking, and this is why the fluorescein was not showing a very high leakage from of the ring. So I have some cases where you actually have a kind of a reaction of fibrosis, and the RP is growing over, and it start to be in autofluorescence again, autofluorescence, because the attachment of the photoreceptor again and the reproduction of lipofuscin, that is quite amazing. So thank you again for the kind invitation. As usual, I have to thank all the top colleagues for inviting me. It's always a pleasure, and I hope you enjoy the cases. Thank you.
Okay, great. Thank you very much, Giovanni. So next, continuing the AMD theme, Phil is going to come back and talk about the assessment of PED volume and how it helps us in managing AMD patients.
Dr. Shada, Dr. Tan, I appreciate the invitation and thank you for organizing this session. What I'd like to do is share with you how some of our work looking at drusen, which you don't usually have here, has aided our ability of following patients with vascularized pigment epithelial detachment. Now these are the individuals that have worked closely with me over the years. I couldn't do it without them. Giovanni Gregori deserves a particular shout out because he's the mathematician who's developed a lot of the algorithms on the Cirrus OCT. And I do receive research funding from Carl Zeiss Meditech, and there is a licensing agreement with the University of Miami. So here's how our research in drusen has benefited our ability to follow patients with pigment epithelial detachments. When we perform Cirrus raster scanning, we always perform this 200 by 200 raster scan approach in which each A scan is separated by 30 microns and each B scan is separated by 30 microns. So that gives us an isodense distribution of A scans across the 6 by 6 millimeter region. So as many of you know, drusen cause elevation of the retinal pigment epithelium. And the Cirrus will segment the ILM, which is fairly normal. But when it segments the RPE, the typical drusen, we see this mountain range of elevation, which represents drusen in the back of the eye. Now what Giovanni Gregori did is he created a mathematical virtual RPE floor here by extrapolating what the normal RPE is like. And then he subtracted mathematically these two segmentations and came up with a difference map in which we could have the area and volume of drusen. What I want you to think about is not only what this is useful now, but when swept source OCT comes out, boy, the sensitivity is just going to be dramatically better. But here we have a case of a drusenoid pigment epithelial detachment. Here's the RPE segmentation. And here's the area and volume map. And you can superimpose them, and on this particular case, where all the drusen are elevated, it registers beautifully. So, what's the difference between typical soft drusen and vascularized or non-vascularized pigment epithelial detachments? And the answer is not much, because you can use the same strategy to visualize and quantify PEDs. So we did the exact same thing. We looked at the PEDs, the RP segmentation, the virtual floor, we subtracted the two, and now we have an area and volume measurement of PEDs, which is particularly useful for polypoidal lesions. And it's highly reproducible and reliable. So here's how I used this algorithm to follow patients with vascularized pigment epithelial detachments. This could be a polypoidal lesion. You can see the pigment epithelial detachment. You can see the subretinal fluid is depicted nicely on the retinal thickness map here. And so now we start our anti-VEGF therapy. Here's what the patient looks like at baseline. Notice the vision is good because you don't have cystic maculopathy here. There's just fluid under the retina, and the fluidal contour is good. So the vision is good. So we're not going to be able to follow vision here. So here's the subretinal fluid, and we treat with Lucentis. Patient comes back a month later, and look, the fluid's going down. A month later, after another injection, much better with resolution of the pigment epithelial detachment. And you can appreciate that in the volume measurement. It's just reassuring to see that the volume measurement is going down. Okay. volume responds, but the vision remains stable. This patient does well. We also observed something very interesting in patients that we were treating as part of our routine clinical care. This measurement of the pigment epithelial detachment volume is actually very useful in predicting when you're going to need to retreat. So this is a patient with a hemorrhagic pigment epithelial detachment. And fortunately, this patient was in a clinical study, not for this eye, for the other eye. The other eye had dry macular degeneration. So this patient happened to develop wet macular degeneration and receives one VEGF injection, and this visit receives the second anti-VEGF injection. You can see the pigment epithelial detachment, the fluid on the retinal thickness map. Here's the segmentation and the volume. So this patient gets the second anti-VEGF treatment and comes in, and 4 weeks later it looks a lot better. The fluid under the retina is gone. The pigment epithelial detachment is slightly smaller, and that's confirmed on the segmentation and the volume measure. So we observed this patient because in this study, the patient's coming back every 2 weeks. So I knew I was going to see this patient in 2 weeks for the other eye. And 2 weeks later, the patient comes back, and everything still looks pretty good. The vision was stable, and the volume, though, is starting to creep up. Maybe you can appreciate here in the RP segmentation map. So we decided to watch. Since the patient was coming back 2 weeks later, the patient comes back. Lo and behold, here's the fluid, okay, and the volume has increased. So we treat, and not surprisingly, the PED volume goes back down. And if you notice, the volume, the fluid's gone. So this was an interesting observation. We then extrapolated with a bunch of studies, a bunch of cases, retrospectively. We went back in all our PRN treatments, and we found that when we looked at the volume measurements of PEDs and we didn't treat, and then we needed to treat the next visit, the volume had already increased at the visit we didn't treat. So an increasing PED volume was a harbinger, an ominous sign of needing to treat later on. I'd be fascinated to find out if you see the same thing with polypoidal lesions. Okay. It's also yeah. Oh, I should add that this is commercially available in the version 6.0 of the series. This is not a research algorithm any longer. This is available commercially. Version 6.0, it's called Advanced RPE Visualization. Okay. So here we have a patient, a 74-year-old woman who'd been undergoing multiple ranibizumab injections. This is what she looked like 6 weeks post-injection, a little fluid here. So we were using treat and extend strategy. We decided, no, it's time to cut back from 6 weeks back to 4 weeks. So here that patient is at 6 weeks, we treat, comes back at 4 weeks, and there's more fluid. 4 weeks later after injection, more fluid, and lo and behold, you see the fluid accumulating, and the next visit, the patient really deteriorates. You want to avoid this. Could this have been predicted? And what we're doing now, we don't have many hemorrhagic cases like this, but what we're finding is that when you have a hemorrhagic case like this, beware of an increasing volume in your PED, another ominous sign for bad things to happen. Again, I wonder in polypoidal lesions, you see the same thing. Okay. So what else could have been done? Well, we didn't have ILEA back then, but now we switch a patient to ILEA. So let me show you a couple cases of ILEA switching in which we quantified the PED volume. This is a patient that was in our dry complete study, the same study as that other patient. And this was the study eye, dry AMD, comes back in 4 weeks later to turn to wet macular degeneration. No problem, we'll start treating. After 20 Lucentis and Avastin injections, given as frequently as every 2 to 3 weeks, not looking good. The PED volume is increasing. Vision, though, is pretty good, 20/20. Once again, you don't want to follow the vision in cases like that. So I give an injection of Lucentis again, bring the patient back in 3 weeks. PED volume, look at that PED, highly reducible, not changing, but this isn't getting better. What do? We switch to ILEA. And whenever I switch patients to ILEA, I always use the same treatment interval. So this patient came in 3 weeks. I want to see what ILEA looks like in 3 weeks. So I treat with ILEA, comes back in 3 weeks. It's better. Encouraged. But you can't keep treating every 3 weeks, so I stretch it out to 5 weeks. It's a little better. Looking good. Still 20/20 vision. So I keep it at 5 weeks. Looking good, dropping a little bit, 5 weeks, 9.2, 0.93, 0.96, maybe it's about the same. So maintain 5 weeks or extend. I think I'll extend to 6 weeks. That PED volume just jumped up, 1.74. Not a good sign. What's the next step? Drop it back to 4 weeks. This is our treat and extend strategy in which we pull back, okay? So now I do every 4 weeks twice. The PED volume's looking pretty good, okay? So what's the next step? Extend to 5 weeks, maybe it's creeping up. The bottom line is, I've never been able to get this patient past 5 weeks. And I've been following this patient now for a year past this point. Can't get her past 5 weeks. But she comes in every 5 weeks and gets her ILE and she's happy, she's 20. Okay? Let me show you another case. And after looking at polypoidal cases this week, I'm embarrassed to say I don't have an ICG of this patient. I think this is a polypoidal lesion. This double hump configuration of a PED with this spiky peak, I think that's polypoidal. So this is a case of hemorrhagic pigment epithelial detachment with lots of exudate that came in and got 8 injections of Lucentis over 8 months. Not looking good, okay? 20/40 vision, stable. Let's switch to ILEA. So this patient gets an ILEA injection, 1 month later looking better, 1 month later looking better, 1 month later, maybe it's the same, maybe it's better. Vision's 20/30 now, okay? Is it getting better? Let's go back now. Is that PED the same? Is it worse? Let's see what happens here. Every month, looking pretty stable, okay? Is it changing? Let's do quantitation, 0.95, 0.83, 0.75, 0.7, it's dropping. So I've learned my lesson. I'm going to continue treating monthly and see if it keeps dropping. It keeps dropping. Okay, let's keep going. Let's keep going. Looking good. Consider extending to 5 to 6 weeks. 6 weeks, did that twice. 8 weeks twice. Still dropping. Looking good. 9 weeks. Dropping. 11 weeks. 12 weeks. And that's where we are now. We're seeing the patient back in 12 weeks. This is real-world management. So the bottom line is, I use this now all the time in my patients with PEDs. And PEDs respond better to ILEA in my experience. And I have a whole series that I don't have time to show you, but it's true. So in the US, OCT is now the gold standard. Now it may not be outside the US with fluorescein and ICG multimodality imaging, but in the US, it's the gold standard. Treat the subretinal fluid and intraretinal fluid. Beware of the PED volume. Increasing PED volume is an ominous sign. And I say pound the vascularized PEDs until you get it as small as possible. Thank you.
Phil, we will let you continue because that was so good.
Okay.
En-face OCT imaging.
So hopefully the algorithms will be developed with the SWEP source OCT so we can do the exact same thing. Unfortunately, you just can't take the same algorithms and apply them to the SWEP source database as VASA type. It requires some alterations. So en-face imaging. So I'm going to show you en-face imaging, how we use it for geographic atrophy. But when I'm doing this, I want you to envision using en-face imaging. And this, again, is available in the advanced RPE visualization software. You can do it for any layer of a B scan. So you can do it in the choroidal layer, you can do it in the RP layer, you can do it in any of the retinal layers. And think about the different diseases and how this might help you understand how disease progresses, or how you can predict the onset of disease. Again, my colleagues, the arrangements we have with Carl Zeiss and Meditech. So, as many of you have seen over the past week, this is the paradigm. We used to think about anti-VEGF therapy, we treat, we convert wet to dry, and now we have this progression to dry macular degeneration. You know, Giovanni brought up we're stuck. Grigori brought up the issue of RAP and whether we should treat. I just wanted to mention, progression to geographic atrophy. I just wanted to mention that RAP was one of the risk factors in the CAT trial in the latest paper for development of geographic atrophy with monthly dosing. So I think monthly dosing, while that may be perhaps attractive because it's such an aggressive lesion, I would still use a minimal dosing strategy, probably treat and extend with RAP, because I'm worried about this. Okay, geographic atrophy, we see a lot of this. You don't. Fluorescein autofluorescence, as Giovanni Sciringi has talked about, is really the ideal way of following this. There are different techniques. I'm not going to dwell on this. In the US, it's mainly a Topcon versus Heidelberg competition. And we see these things here, reticular pseudodrusen, which I was fascinated to learn this week. You really don't see them. And I think this is a really important observation of why we get geographic atrophy so much, and you don't see them much at all. There's got to be a genetic basis for this. But we've been using spectral domain OCT fundus imaging, which is an en-face imaging strategy to follow patients with geographic atrophy. And again, we're using this exact same scanning technique. I like the scanning technique because I do it on all my patients, whether they're dry or wet, and it allows me to go back and look at different algorithms because I always have the exact same scanning technique. Okay? So the OCT fundus image is up here. Okay? That's an en-face projection image with the Cirrus printout. A lot of people think that's an SLO image, but it's not. That's a projection image. And the reason why geographic atrophy looks bright is if you integrate all the light that's reflected here, if you summarize, you see that where the RPE is intact, you have scattering at the level of the RPE from the melanosomes, and where the RPE is gone, you get deep penetration. So when all the light is reflected back to the detector, it appears brighter compared to where the RPE is intact. Okay? That's why geographic atrophy, because when all this light is reflected back, it appears brighter. Okay? And you can see in this case with the color fundus image, it looks very much like the autofluorescence with the en-face image, where you really don't see it too well in the color fundus image. Okay? So this is how we create the en-face image. We collect all these B scans, all right? And essentially what we're doing is we're taking a slab. This is a slab that goes from this red line here to 400 microns below the RPE. Because we can segment the RPE, we know exactly where this is, all right? And then essentially what we're doing mathematically is we're looking at this, that's why we call it a slab. We're looking at the slab, and then we remove the bottom and the top, and then we look at it en face. Okay? That's slab imaging. But you can do it with any layer. Okay? If you can segment it, then you can do it from a distance from the ILM or the RPE. Okay? So we come up with an enhanced slab called a soft RPE slab, which gives you a little more contrast. And the way this is done, and this is available on the advanced RPE visualization too. Let me go back there. So this is, it's from the RPE, sorry. RPE to 400 microns, so we don't include that material that's above. And once again, we do the exact same thing. We take the slab, and we remove what's on the bottom and what's on the top. And now it has a little more contrast, and that's useful because we have an automated segmentation algorithm that's on the Cirrus that allows you to measure the areas of geographic atrophy. Even if it's not quite right, you can edit it. Okay. And this is what the printout looks like, and you get all that information below. You can do one visit and compare it to another. So we wanted to ask the question, we're going to now change our direction a little bit and ask the question, is there a layer of the retina that's abnormal in dry macular degeneration around the geographic atrophy that can predict where the geographic atrophy is going to grow? And there was a lot of preliminary work going back to Shirley Sarks in the 1960s showing that photoreceptors are abnormal away from the edge of geographic atrophy. And I wonder, if you look at polypoidal cases, whether there are abnormalities in photoreceptors above where the polypoidal lesions are going to develop. So we looked at a bunch of cases with geographic atrophy, and we used the same scan pattern, only this time, what we did was we looked at the ISOS zone. ISOS zone, or boundary.
Ellipsoid zone.
And that was a 20 micron slab that goes across this band that we've all identified previously in our scans. that represents photoreceptor integrity, okay? And we do the exact same thing, right? We take a slab, only now it's 20 microns thick, okay? And we remove what's on top and what's on bottom, and now we're looking at an en-face image of this 20 micron slab. And all the noise is due to speckle noise, as Dr. Sada had mentioned, and this is the normal appearance, and I'm sure that noise will be a lot less with the swept sources clear. Okay, and once again, we're looking at a 20 micron slab here. And notice how that ISOS boundary area is elevated, so inside the slab it's dark, and that's why it appears dark. Okay. So, let me just show you some cases of geographic atrophy, patient with bilateral geographic atrophy. In our population, they tend to be symmetrical, so this area will grow to be as big as this area. Here it is on autofluorescence, here it is on the slab, and here it is on the ISOS slab. This is the area of geographic atrophy that's shown here. And notice this dark area above here, okay? And now when we look at the growth of that area over here, we look at this dark area here, and now we're going to draw where the geographic atrophy grows over 6 months. And you can see it grows into this area that's dark. And what I want you to appreciate here is if you look at a B scan through a normal area, the B scan here, outer nuclear layer, looks good. And then if you go through the dark area, you can see total disruption of the ISOS band and thinning of the outer nuclear layer. So these photoreceptors were already dying. And they were thousands of microns away from the edge of GA.
Can you go back on that real quick?
Yeah, the autofluorescence is very useful too.
I was asking, do you think that the increased autofluorescence is due to the thickness of the RPE, or due to the fact that since you don't have any more of a masking photoreceptor?
Here.
Yes. It's
You're
actually
losing the photoreceptors.
you're losing photoreceptors.
So it's like you're bleaching, right?
Exactly.
Yeah. I
So
get
if you
it.
bleach,
Ooh.
probably the autofluorescence should not be seen.
See? Isn't that great?
This is the argues when we, what if us really need to do pre and post bleach images, probably routinely.
Ah, this is great. This is good. Okay? So photoreceptors are dead here. They're dead. Dead. We just haven't appreciated it because the geographic atrophy hasn't grown into that area. Ooh. Just one other case. This is an area with crescentic geographic atrophy. Once again, we know eyes tend to be symmetrical. This is what the eye looks like when we're seeing the patient at this visit. And notice this dark area here. Right? It's predicting where the geographic atrophy is going to grow. And indeed, this is what happens over the course of 12 months. It's where the geographic atrophy grows. And once again, when you look at B scans, to a relatively normal period area, it looks normal, and you go through the area in which the photoreceptors are disrupted and the outer retinal is disrupted. You can do this in diabetes, you can do it in polypoidal disease. Pick your disease and you can do it. Okay? Even this little patch down here, you can see disruption and thinning of the outer nuclear layer. Okay, so we found this to be very useful for following patients with dry macular degeneration and following the progression of geographic atrophy. Okay, now there's this one other disease I'm just going to touch on quickly. It's called macular telangiectasia type 2. You do have this here. We didn't think we had much of this until we started looking for it. But it's a very unusual condition. It's bilateral, presents as these crystals and this whitening of the retina here, this grayish discoloration, and you get leakage initially, temporarily, and many times there's more retinal pathology than you appreciate, and there's atrophy. So why not apply the same algorithms that we were applying before? And people have been doing this manually, what I'm about to show you, but now we have an automated algorithm that can do it. This is a patient with some earlier onset leakage, temporally in this characteristic OCT finding, draping of the ILM here, these cystic, slit-like cystic changes. But there's also some darkening here, some abnormality in this area that would appear normally dark in the ISOS slab. But that's because that's where a lot of pathology starts. And this is a slightly more advanced case. To get these cookie cutter defects, you can see this increase hyporeflectivity between the IS-OS zone and the RP here. Okay. So we're part of the MACTEL project. We have over 100 patients now. This is a global initiative coming out of Australia to try to figure out what causes this disease. So we applied the same slab technique that we did with geographic atrophy, right? In which we're looking at this 20-micron slab and start in the center. And this is what you see. Just remarkable. It just jumps out at you. And now this is a really convenient way for following disease progression. And it's actually going to be used in a clinical trial looking at the growth of this area, right? And notice the difference when the retina collapses into this area, it appears slightly grayish where there's fluid, it's all dark. Okay? So this is just an early case. You can see the grayish here, and a more advanced case where it's dark. But you know what we also saw is this just isn't a disease of the retinal vasculature. The choroids are really abnormally thick in this disease. So I'm really interested in looking at choroidal abnormalities in MACTEL as well. They're abnormally thick compared to normal controls. So we use ONFOS. ONFOS is really a strategy that's just now taking off. People are just now beginning to appreciate it. We've got a big meeting in Rome on December 14th in which people are going to use different strategies, different instruments to image retinal diseases using ONFOS imaging. Thank you very, very much.
Thanks very much. So we're going to move to Colin. Mark Devine is not going to give you his talk, but we've got time for Colin to give both his presentations. So we're going to bring us home, Colin. First on OCT and myopic eyes.
Okay, thank you, Dr. Sada. So, well, we're in the home stretch already. Two more topics to cover, but I think we'll also save some time for questions and answers for everyone. So, first of all, I'm going to talk about the use of OCT in myopia. I think this is a subject that's especially relevant in locally because obviously many of us are myopic to varying degrees, and that's something that we see very commonly in our clinics. So as we know, I'm sure we all know what myopia is, I'll skip that. And these are, of course, some of the findings that can happen in a myope. Sorry to depress everyone, but the chororetinal atrophy, the thinning, the tilted disc, peripapular atrophy, and yet fairly normal patient at this point. And so obviously, how does OCT help us? What can we see, and how can we use it to diagnose the various findings and diseases, and also what are the problems that myopia causes? So we know what OCT is, and it's been shown to be helpful in some assessment and prognostication, but especially it's useful to look for the features of pathological or high myopia, and to identify changes that which conventional clinical examination or photography, funded photography, may not be able to detect. So there's one paper that has described some findings, some measurements such as the minimal diameter and the whole form factor, which has been shown to correlate very closely with the prognosis for myopic macular hole surgery, and both the higher whole form factor as well as the lower minimum diameter were associated with better primary closure rates. I would like to talk a bit about the various features of OCT, of myopia background that we see in OCT. And of course, this will include things like choroidal thinning, the presence of macular holes, foliosthesis, and CNV. So this is an example of a patient, a very high myope, with and taking a single B scan through the retina. And whilst the retina is fairly intact, we can see that the choroid is very thin, it's very thin, and so much so that we are actually able to visualize the underlying sclera, and this area is actually the orbital fat, so you can see all the way right through to that, and that's very dramatic. Sometimes when some residents join me in clinic in high myopes, when I ask them where the choroid is, they'll just point at this dark band here, because that's what we're used to seeing in less high myopes. But what I must realize is that this split is very, very thin in a very patient very high myopia. And this has been shown. We've looked at the literature, and we can see that in various diseases, it's been shown to be higher, but in severe myopia, it can be as thin as 93 microns. right? So looking at some of these other results, I looked at my own choroidal thickness, and well, it's not that bad. It's in triple digits, so I'm still happy, but it's a bit low. So yeah, we can detect macro holes on OCT. I'm sure we're all familiar with the issue whether there's a full thickness macro hole or whether it's a lamellar hole and things like that. And obviously we've used clinically the Watson-Allen sign and so on, but OCT can show us very clearly the various where there's a disruption or whether it's just a partial thickness macro hole. And sometimes in myopes, one study found that it's as high as macro holes can occur as high as 6% of cases, even though they're asymptomatic. Myopic foveal schisis is also very important. It can be pretty high, and this is where you see a very large separation of the retinal layers. And some of these patients may still have very good visual acuity. Another example, a very high myope with schisis in one area. Some of these may not necessarily be right in center, so as Dr. Sada mentioned, very important to review all your E scans in the OCT to detect it.
And a good conjugate image artifact too.
Yes, exactly. So this is, and of course myopic CNV is something that we probably would have seen. This is actually a patient from our series paper that I did with Professor Lin, where we just showed the various, some different lesions of myopic CNV. And looking at the OCT, so we can, these are patients from our clinic where we can see that in the active lesion, the CNV lesion is usually smaller than and less widespread than, say, a typical AMD or PCV, but and there's not very much scar to it. But this is the scar stage when it's already resolved with treatment, but it still forms a scar there. So some other findings that have been described that may be of interest in future is peripapillary intrachoroidal cavitation. That's already a mouthful. The term was even longer before, but it's been described in very highly myopic people, and some studies have shown that they have glaucomatous visual defects in up to 70% of these people. And what you see is this gap between the choroid and the rest of the retina around the optic disc. And clinically, this supposed to have a yellowish orange lesion. Although, frankly, I don't remember having really seen this. Maybe I'm just not looking for it. And sometimes also a finding that may surprise us is the perivascular retinal cysts. These are areas of rarefaction around the vasculature where there are hollow spaces near the large vessels. And so OCT, of course, would reveal this, and many a time they are actually asymptomatic. It doesn't really cause any problems, but if we're not careful, we may be alarmed and wonder whether there's some disease process going on. So, but the key is to really look at around the vessels. Is usually around right near the big vessels, and this has been shown to be more common with those with very increasing axial length and especially those with posterior staphyloma. And sometimes they also have microfolds, which are caused by the tenting of the retinal vessels because they're less flexible. So it's important not to mistake this for pathology. So I'd like to talk a bit about what features of myopia make OCT interpretation difficult. One of which is the presence of staphyloma, because the OCT has a certain range of imaging so as to see the various structures clearly, and a very steep staphyloma would cause problems with that. And also, Dr. Salas mentioned the mirror image artifacts such as this, and so this is something that you have to get used to in a way, and just basically know which region of the eye you're concentrating on. I think also a good tip, which Ethan, if you don't mind, I'd like to share with I heard from Ethan on 2 days ago during the course, is to narrow the scan length if you're just focused on the area of interest, and that will have the curvature will have less of an impact on the imaging. Did I get it right? Okay. So also segmentation errors. Now, Dr. Sada mentioned the importance of segmentation errors in when you look at color map, now this can occur in any eye, especially those with disease, but it's in myopes. If you go and look at the color maps of those patients, even asymptomatic patient with no active disease, I think you'll see that it's usually a very variegated appearance. And that's because with the various structural effects of choroidal atrophy, thinning, and so on, sometimes the segmentation algorithm has difficulty spotting this. So it's a mess, really. And I certainly would not want to take that as, take differences between visits and increases or decreases as a sign of a disease or disease improvement, without reviewing segmentation errors. I think that's something that is very important. So I mentioned mirror artifact, and so it remains to be seen how swept source OCT will help us in imaging of high myopes. I think we discussed the origins of swept source OCT. It uses a tunable laser in order to obtain the image, and besides, it has obviously a wider range of scans, and you can see both the retina and the choroid more clearly. But it's been shown in some publications to be more useful in highly myopic eyes, such as this one, where you can see the the detail is really good all the way from the top to the bottom of the statuloma. And this is just an example from one of our own patients where the spectral domain OCT shows us the choroid. This is EDI scan, but we don't really see the rest of the findings above. And of course, posterior vitreous detachment and is more common in myopes. Just to point out that sometimes even in using the swept source OCT, you can get this artifact. So it's not entirely a magical solution to this. Okay, so in conclusion, I think OCT is very helpful in identifying the pathologic features of myopia. We can visualize the choroid with EDI, and this is something that is important because we always suspect that choroid has a role to play in myopia. And also we must always remember the features of myopia that affect the quality of the OCT scan and our interpretation of it. Okay, I'd like to acknowledge again my team that's helped work with me on these various projects. Thank you.